Hey, this is Joel Topf for Nephrology Times, and I'm here with Rodby and Edgar Lerma, who just finished their ASN poster tour, ASN Kidney poster tour. You guys have been doing this for a number of years. How long have you been doing it for?
Gosh, I don't know, 4 or 5
Yeah.
ASNs.
Yeah. And then we stopped during COVID.
You stopped during COVID, and I mean, your poster tours are legendary. What makes a Roger and Lerma poster tour, what's the secret sauce there?
The secret sauce, well, it's teamwork for sure, because I pick them out, and I try to pick stuff that I think's clinically relevant that might be interesting. It's often case reports or something that's really unique and there might be a lesson for, as opposed to some super complicated science that we might not understand. So it's very clinically oriented. And then Edgar makes visual abstracts for every one of them, and then he releases them and kind of summarizes them into really nice little abstracts. So it's worked out really well. We also have this shtick that we do there where we're the Blues Brothers, and so we've taken all these pictures, and we both wear sunglasses, and he's John Belushi and I'm Dan Aykroyd. So that's kind of our shtick. But
it's a Chicago thing.
It's definitely a Chicago thing. We are from Chicago. Thank you. Yeah.
Excellent. And so what was your favorite poster from today, or what's a memorable poster from today?
Well, why don't we just do a couple? I mean, maybe do a couple each very quickly. We went to about 7 or 8 of them. One of them I really liked was a poster on a genetic abnormality where these patients had a cubulin mutation, so their cubulin didn't work. And cubulin is a proximal tubular protein that reabsorbs small molecular weight proteins. So what they ended up having is proteinuria because they couldn't reabsorb normally small molecular weight filtered protein. And the whole idea was that proteinuria is bad, and proteinuria causes fibrosis, and proteinuria is part of what causes CKD with all these GN diseases. But this is a proteinuria that's not from a glomerular problem. It's a very different type of protein and a very different problem, and it doesn't reflect the glomerulus. And the question is, if you have chronic tubular proteinuria, unlike other proteinuria, we develop renal failure. And this patient did really well for, I don't know, was it 12 years or 15 years or something, did really well. And it's kind of a nature's example that tubular proteinuria is probably very different. It may not be a risk factor for CKD, and it also is relevant because it's when we target patients with CKD, we target their proteinuria, but we may not necessarily need to target tubular proteinuria. It may be a very different problem. So I thought that was really interesting.
And actually all of our drugs probably will not affect this at all, right?
No, they probably won't, because that's all about hemodynamic, you know. He said that there's a possibility in the future that, because part of the problem with how proteinuria does cause renal failure is the filtered albumin gets reabsorbed and the tubules get overwhelmed, and that might lead to fibrosis. And so
there's no
just by lowering, so if you could actually find a drug that blocks cubulin, you might be renal protective. It's pretty interesting.
That is pretty interesting.
I love these things because it's genetics. I'll tell you, almost all our posters today ended up with some talk about genetics.
Excellent. Edgar, what was one of your favorites?
So I actually had a couple of favorites. The first one is the case report of a patient with, turns out to have calciphylaxis, who was resistant, or not resistant, but intolerant of sodium thiosulfate. So in this patient, what they did was they used a mega dose of vitamin K, 10 milligrams 3 times a week. And actually, they showed a picture of the patient pre and post treatment. And again, it is very, this is something that's germane to CKD management, right?
It's such a frustrating condition, and I always feel like I don't have anything to offer so many of these patients.
So it's interesting that they use PO vitamin K, I'm sure it's many tablets, but it's cheap, right?
Yeah.
And so it's not cheap, that's the problem. It's cheap, and one of our poster members was from Poland. He says, you get 20 for $1 or something, but here this guy actually had to pay for it himself. But it was you've seen the before and after pictures of calciphylaxis from sodium thiosulfate. This was exactly like this, just cavitating lesion that completely heals with vitamin K alone. And vitamin K is a factor because we know that's the warfarin relationship.
Right, for sure.
With the GLA protein, and so it made sense that they would do it, but it's a single case. But I've never seen these things get better on their own.
Yeah, and I love that creativity when people think about how the disease mechanism and what could we possibly do to offer these patients. That's great.
Yeah.
That's great. So you make these visual abstracts. Do you ever find that your visual abstract is better than the poster? Do you go there and you have this person looking at your visual abstract like, can we just trade that?
The beauty about doing a visual abstract of the posters is that there's limited material. So
Yes,
there's
yeah.
limited material that you need to put in the visual as compared to a full paper with a supplement that you have to go through before you create that visual abstract. So for me, it's easier for me to do this as compared to a full paper. So.
And you've been doing this for 5 years now. Do you look back and over the scope of that 5 years, can you see the progress in nephrology that we're all kind of witnessing? Can you see that in kind of what you've seen in the poster presentations?
Well, I basically just said it. I mean, 5 years ago, we weren't talking about genetics for every poster.
Right.
It
That's
wasn't
right.
available. And now, we had hyperoxaluria, we had genetic testing, which found focal sclerosis, was not focal sclerosis, it was Alport's.
Yep.
We found several, and the cubulin was, so there's a lot of difference. And kept coming up, well, had we done this or known this before, maybe this patient wouldn't have had renal failure, maybe this patient wouldn't have needed a biopsy. So yeah, that's, I think, the big thing. It's a really exciting time in nephrology, having that available.
I think, Joel, I think having genetic testing in the limelight now, it's readily available, it's easy to do, it's easy to order, makes us go to the next phase of maybe diagnosing these diseases, right? As Roger mentioned, one of the posters that we saw was a patient was diagnosed to have FSGS, turns out to have X-linked Alport syndrome later on because they did genetic testing down the road. So I think, 5 years ago, we weren't talking about genetic testing. Maybe here and there, but now there's a lot.
That's excellent. That's excellent. So, any changes in the future for the Lerma and Rodby show here? Any anticipated changes?
I don't know, I think we're a staple.
You got it done.
We're in it for good.
So, and I got to ask, is how many people do you have on your tour?
One more than NephJC.
Oh, that was a joke I was going to use. Hey, gentlemen, thank you for joining us.
Thank you, man, that's great.
Joel Topf for Neph Times.